is my honor to introduce today's speaker, who is one of us. He's a faculty member in the department. Dr. Chavez is a psychologist. He is in the CCPHC. He's in the Behavioral Health Division, Community Behavioral Health Division, and he's doing very important work. His work has included areas such as culturally centered interventions and community engaged work with Latin communities affected by substance use disorders, immigrant experiences, as well as LGBTQAI issues. Today, he's going to be talking about issues related to DEI, and he's going to be doing an exercise with us. But why don't we have Dr. Chavez let us know what is going to be the focus and the goals of his presentation today. Dr. Chavez.
Sure. I'll go ahead and start sharing my slides here. If I could just have a moment. I know it's a little challenging sometimes to get the slideshow going, but I hope that you can see. Let's see. I hope you can see the slides and not my notes.
Dr. Chavez, right now we can only see, we can kind of still see the entire PowerPoint page,
Just
not
put
just
it
your
in
slides.
presentation mode, Dr. Chavez.
Yes.
Okay, let's see here. Let's see.
We don't see the slides now. Perfect.
Okay, so slides and no notes. Okay.
Yes.
Okay, great. Well, thank you very much. It's always an honor to present and taking this opportunity to talk about DEI cases. And it's I try to really focus on, our very own setting, our own very own professions that that we are a part of. And throughout this talk, I'll also focus on some of the work that the School of Medicine in general has been doing in terms of DEI within the overall School of Medicine. And so, but before I get started on all that, I do want to, as a practice, I'm going to bring into this space what we do within DEI meetings is to honor communities who have contributed to everything that we do across the state. And so I'll start off with some acknowledgements that are practiced even within our own School of Medicine DEI rep meetings. And I'll go ahead and read along these, but founded in 1889, the University of New Mexico sits on the traditional homelands of the Pueblo of Sandia. The original people of New Mexico, Pueblo, Navajo, and Apache, since time immemorial, have deep connections to the land and have made significant contributions to the broader community statewide. We honor the land itself and those who remain stewards of this land throughout the generations, and also acknowledge our committed relationship to Indigenous peoples. We gratefully recognize our history. We also have at UNM, we respectfully acknowledge the traumatic history of forced labor of Black Americans who have advanced our country. We are indebted to the enslaved and exploited African Americans who established our U.S. infrastructure and economy, advanced civil rights, and continue to influence popular culture. We are obligated to continuously recognize historic and current systemic oppression and injustices placed on Black Americans. We are grateful for their ancestors, for without them, we would not be where we are today. And one more, to honor immigrants in the United States. The United States of America is a country that is built on strength of immigrants that came here either voluntarily or involuntarily. Whether they look or speak differently from us, we will do our best to understand, respect, appreciate, and value their cultures and contributions, with the ultimate goal to welcome them and elicit their potential for the betterment of all societies. So this brings me to our dialogue today, our discussion today. I will look at introduce, if you have not already done so, but review the missions and the efforts that have been done up to this point within 4 major behavioral health associations. And I'll also share a little bit about some literature that has started to come up regarding the experiences of trainees as well as mental health professionals in regards to DEI. Then I'll also go into 4 cases in particular that looks at intersectional identities, specifically to research in academic settings in behavioral health. And then finally, I'll provide some multi-level strategies to address DEI issues that hopefully we can implement as a community. So I'll start off with, in no particular order, with the American Psychiatric Association. But before I even get into this, the reason why I wanted to address these issues is that during my own personal training as a psychologist back in the early 90s, multicultural issues, diversity, etc., there were not big topics really that were discussed in my programming, in my training, my early practicums, and early internships. And especially in my undergrad, and I actually ended up taking a whole different route, and because I wanted to focus on multicultural issues, and I actually, for my master's, went into counseling, which was historically centered on multicultural and developmental perspectives. And so early on, these organizations didn't really have these efforts towards DEI, but once again, within the American Psychiatric Association, there's the Division of Diversity and Health Equity, which is dedicated to eliminating disparities and promoting equity in mental health care. The focus is on underserved population, working to address the needs of diverse patient populations and increase representation of psychiatrists from underrepresented groups. Strategic plan outlines goals for enhancing DEI within the organization and the field. I also added here, the accrediting body of psychiatry training programs, ACGME, and who actually has a really great page that addresses, that's called Equity Matters, which is an initiative that applies a framework for continuous learning and process improvement in the area of DEI and anti-racism practices. And this initiative aims to drive change within medical education. And so by increasing the physician workforce diversity and building safe and inclusive environments, while promoting health equity by addressing racial disparities in healthcare and the overall population health. But they provide some of these 4-credit micro courses on history of race and medicine, gender disparities, etc. It's an impressive website, actually. So I provided that link if you are interested. And within the American Psychological Association, as I mentioned, I was an undergrad in psychology back then. Cultural issues, it was a cross-cultural class that I took, and so issues of diversity were not well integrated into the programming. Needless to say, they do have an office of DEI as well that leads the efforts for DEI. They have a pretty substantive action plan that outlines specific steps to address systemic racism. And they also talk a lot about developing diverse leadership. So, again, emphasizing the importance of inclusive leadership. And so they have developed, on the bottom right there, you see their EDI framework, which guides their overall work in promoting equity, diversity, and inclusion. More recently, with the last president, there was a development of culturally informed toolkits, one including this on trauma and grief toolkit, which has great resources for anyone that wants to do culturally centered work. And then there's also National Association for Social Workers historically have had a strong commitment to DEI, and since a very long time have incorporated the DEI concerns into their code of ethics. They work to address social injustices and promote equity for all. And they also provide training and materials on DEI for social workers. And they recently have more taken on or created these statements on anti-racism and anti-oppression, really emphasizing that framework or that lens. And then finally, I have the American Counseling Association, what I'm actually a member of the association as well. And but they also strive to a broad range of counselors from diverse backgrounds. And they have developed a set of multicultural counseling competencies that provide guidelines for counselors to become more culturally sensitive and effective in their work with diverse populations. So these competencies address various aspects of diversity, including race, ethnicity, culture, gender, sexual orientation, disability, and socioeconomic status. But they have a huge commitment to social justice, promoting advocacy for marginalized populations. And they offer resources, once again, and training for DEI for counselors. And they also do have on that link that on the top of the slide there is a website full of DEI topics and trainings for continuing education as well that focus on DEI issues. So this brings me to some concerns that I've had. So within each of the associations, they have strategies and their plans, and they're mostly efforts to address how we approach who we serve, the community, individuals and families and communities that we serve. And so there's not too much discussion about the experiences of a marginalization or discrimination experienced, let's say, by trainees or the mental health professionals who are already out in the field. So here I provide a little bit of current literature on the experiences of trainees and learners and providers. But it's very little. It's still growing. And so I think this is a big area of work that still needs to be done to better understand the experiences that we have within behavioral health settings. And here, most of the literature is within the medical health profession in general. And just a few here that I provide here on specific identities as well. So we have to take note that discrimination can be compounded, intersectional. So multiple marginalized identities are often in play at the same time. And literature in general often addresses that intersection of that race, of gender and ability, and sometimes their sexual orientation. With multiple marginalized identities, of course, comes compounded stressors as well. So we have to keep that in mind. Of course, many of us may have been taken training in microaggressions. One thing very important to note here is that folks who are continuously addressing these multiple levels of discrimination and microaggressions on a daily basis, often end up having symptoms of psychological trauma or PTSD. But other folks have in these articles and other articles talk about intimidation, exclusion, harassment, etc. And in regards to folks with disabilities, it's a topic that's not very often recognized or discussed. But the lack of physical accommodations and access. So there are physical barriers and accommodations for learning for trainees as well as for folks who might have some sort of disability, whether it's physical or intellectual, etc. And oftentimes, folks talk about the lack of institutional support. We also have to address these issues of dealing with stigma. For example, a therapist with chronic illness might be dealing with that, or a provider who identifies as transgender may be stigmatized in our very own academic and medical communities. And but all this contributes to barriers in their own development, career development, career trajectories, growth and learning. Of course, unequal opportunities in pay or advancement, opportunities for mentorship, quality mentorship, and even opportunities for grants or grant funding. So it's restricted to particular topics, for example, and not necessarily for, let's say, LGBTQ plus issues. So those are not very often out there. But I'm sure we can think of other experiences to add to this list based on each of the intersectional identities that each and every one of us carries. Each of our identities that we carry do come with advantages as well as disadvantages. Some come with more power than others, et cetera, within our society and within our very own institutions. So more so on how it impacts our well-being. Some of these 3 articles here talk a little bit about the impact. I mentioned PTSD, psychological trauma, but there's a lot of reports of stress, burnout, so on and so forth. Even our physical health is impacted, high blood pressure, et cetera. But there's a lot of reports on work dissatisfaction. But not only at that individual level are we impacted, even our relational well-being is impacted, in terms of professionalism and how do we connect with the community, and collaborations that we develop are impacted by discrimination overall. So in this section, I will provide 4 case examples that are based on common themes that come up in the literature. They are not based on any specific incidences or that have occurred, let's say, here or at any particular university setting. So they're completely made up characters and DEI situations, once again, that are often common across different university campuses. And so what I'll do here is I'll read each case aloud to you to allow you to reflect on and identify the DEI issues. And you might reflect on how they may relate to your own or others' experiences. And you might also reflect on what strategies need to take place to mitigate the issues, maybe beyond what we've already are starting to practice within our own spaces here at UNM, for example. But our first case, I'm going to talk a little bit about, provide a case and some themes on sexism and see what you can recognize in this situation. But once again, I'll read this out loud. This is the case of Dr. Emily Carter, who's a promising young clinical psychologist and a tenure-track assistant professor at a prestigious university. And despite her strong publication record and positive student evaluation, she consistently faces challenges in her academic career. Dr. Carter is one of only a few female faculty members in her department, and she often finds herself the sole woman in faculty meetings and conferences. Her male colleagues are consistently given more opportunities for research grants, conference presentations, and committee assignments. Dr. Carter often finds herself taking on additional administrative duties, such as advising graduate students without commensurate recognition or compensation. And during faculty meetings, Dr. Carter's ideas are often overlooked or attributed to male colleagues. Her research is sometimes seen as, quote unquote, less rigorous compared to her male counterparts, despite similar methodologies. Dr. Carter learns through informal conversations with colleagues that she is earning significantly less than male faculty members at the same rank and with similar qualifications. And Dr. Carter experiences subtle forms of inappropriate comments and unwanted attention from male colleagues and students. When she reports these incidences, her concerns are often minimized or dismissed. And so I'm going to break this down a little bit more by providing some sub-themes. And I'm sure that you're already thinking about particular issues that are more salient for you. If you feel you want to share what you observe, you could do so in the chat as well. But on our second bullet there, this is an issue of underrepresentation of female faculty members, being the only woman in faculty meetings and conferences. Unequal workload, giving extra duties without recognition and compensation. The experience of dismissive attitudes from male colleagues, basically looking down on her particular approach to her research. And salary disparities, which is a common theme when we talk about sexism. And finally, experiences of sexual harassment, which of course we all take training, is a whole other training in of itself. But in this case, often disregarded or not taken care of or ignored by the institution and her experience. In our second case, I will discuss a little bit here on ethno-racism, but again, we have to think about each of the incidences come with multiple identity categories that might be marginalized. And so here we have the case of Dr. Anya Petrova, who is a highly skilled psychiatrist from Russia. She has secured a tenure-track position at a prominent American university. And despite her impressive credentials and research contributions, she faces a myriad of challenges. Dr. Petrova is often stereotyped as having a thick accent, limited English proficiency, and a lack of cultural competence. Colleagues and students make insensitive comments about her nationality, questioning her ability to understand and treat American patients. Dr. Petrova is frequently invited to speak about her experiences as an immigrant, but her expertise in psychiatry is often overlooked. She feels pressure to represent the entire immigrant community rather than being recognized for individual contributions to the field. Dr. Petrova's research is often undervalued or rejected by academic journals, despite its quality and relevance, and reviewers frequently cite concerns about the generalizability of her findings to American populations. Dr. Petrova faces challenges in securing research grants due to biases against foreign-born investigators. Reviewers often express skepticism about her ability to manage a research project in the United States. So once again, I'm sure you've already recognized some issues here. The second bullet point there, dealing with stereotypes and microaggressions having to do with her accent or limited English proficiency. Questioning who she is as being Russian, for example. Being tokenized, being seen as a person who represents a whole entire immigrant community. Despite being a Russian immigrant, she might have to speak on behalf of all immigrant communities as if she could do so or had that similar experiences. So there's limited mentorship and not being supported by others in her community. And of course, some publication biases at that system level. And then obviously the discrimination and grant funding, what's available to her is not equally distributed. There's another practice on ableism. And in this case, we have Dr. Ethan Ramirez, who is a social worker with a physical disability, specifically using a wheelchair, and who has earned a PhD in social work and secured a tenure-track position at a reputable university. Despite his academic achievements and clinical expertise, he encounters significant challenges. The university campus is largely inaccessible with limited elevators, narrow doorways, and uneven sidewalks. Dr. Ramirez frequently faces challenges navigating the campus and attending departmental meetings or conferences. Colleagues and students often make assumptions about Dr. Ramirez's abilities based on his disability, and he frequently experiences patronizing behaviors such as being offered unsolicited assistance or being spoken to in a condescending tone. Dr. Ramirez is often assigned additional committee work related to accessibility, such as serving on the Disability Services Committee without receiving appropriate compensation or recognition. And despite providing documentation of his disability and requesting reasonable accommodations, Dr. Ramirez encounters resistance or delays in receiving necessary support, such as accessible technology or modified teaching schedules. Dr. Ramirez is frequently asked to speak about his disability in public forums, often reducing the expertise to his personal experience, rather than recognizing his academic contributions. So once again, Dr. Ramirez is facing architectural barriers. That's something that I've tried to be much more conscious of, not identifying as someone who has a physical disability. But we can take that for granted quite often as we walk along our daily lives on campus, for example. Attitudinal barriers from students and colleagues, making particular assumptions about his ability, focusing on the disability only, or making assumptions about his intellectual capacity solely based on that physical appearance. And then also, like the previous case, having a disproportionate workload, also being tokenized, speaking on behalf of folks who have a disability. And quite often, when I was teaching on main campus, this was quite often an issue, the lack of accommodations, it often took quite a long time. There's extra measures that folks with physical disabilities have to, or any disability, that have to take, to process the need for their accommodations and getting that met. And, often dealing with these stereotypes that impacts them personally as well. And our last case here, I'll share a little bit on transphobia and homophobia. Oftentimes people have a hard time distinguishing between sexual orientation, gender identity, and gender expression. And so I think that's a big issue that comes into play that I think most folks need. There's a lot of need for this type of training and attendance to this type of training. But needless to say, Dr. Alex Turner is a non-binary mental health counselor and community-based researcher at a large public university. They specialize in providing culturally competent care to transgender and gender diverse individuals. And despite their expertise, Dr. Turner faces significant challenges in their academic and research environment. Colleagues, students, and even supervisors consistently misgender Dr. Turner using their former name and incorrect pronouns. This creates a hostile and invalidating work environment. Dr. Turner's research proposals focused on the mental health needs of transgender and gender diverse communities, which are frequently rejected by funding agencies, with reviewers citing lack of relevance or methodological flaws. Dr. Turner feels isolated and marginalized within their department, often not linked to informal networking opportunities and mentorship programs. And there have been instances where colleagues or students have intentionally shared with others Dr. Turner's transgender status without their consent, sometimes assuming their sexual orientation as well, and leading to harassment and discrimination. The university lacks clear policies and procedures to address transphobia, and when Dr. Turner reports incidences, there is often a lack of support or accountability. So let's go ahead and look at the sub-themes here. Misgendering and dead naming. Within this narrative here, I use the their pronoun, for example. That can get kind of confusing if we're not used to using them, their, and pronouns. For those who might not know, dead naming is the issue of using their former name before transitioning. And so, which can create, invalidating who they are. And there's discrimination in research funding, once again, not seeing the relevance of the particular topic. And then exclusion from particular committees, networking opportunities, mentorships. Being outed is pretty common for those who do not want to be outed. It's, it can become a dangerous situation, one, not only from discrimination, but, violence is an issue that might come into play when someone is outed. And then lack of institutional support. Oftentimes across these different cases, we forget to actually be very mindful about the specific needs of particular groups, whether it has to do with gender, sexual orientation, racial identities, immigrant status, so on and so forth. So before I go further, is there if there's any questions or thoughts, comments, concerns, anything that comes to mind or so next here, I will go ahead and address the need for multi-level impacts. Going back to the cases, the first case, we can address, I'm going to take it from the top down, actually. When there's a system that's not addressing unequal pay or, not being equitable about promotion opportunities, et cetera, or there's biases in grant funding, so on and so forth, lack of support or either through mentorship or through funding, et cetera, that tends to create a hostile environment, these lack of diversity initiatives at the institutional level, that we're not able to really take note and be more mindful of, the accommodations, the accessibility that we have within our institutions as a whole. And then which in turn impacts us interpersonally. There's mistrust, feelings of disrespect due to the stereotyping, tokenization, the microaggressions, being patronized, being misgendered, et cetera, and ultimately having these individual level effects. Once again, like I mentioned, the stress, contribute to poor self-esteem, anxiety, post-traumatic stress, so on and so forth. So other impacts that we have to take into consideration is one example is decreased productivity. So discrimination and harassment, once again, create a hostile work environment, leading to reduced employee morale, job satisfaction, and just overall productivity. When someone leaves the institution, there's a loss of institutional knowledge. So that departure of an experienced person due to discrimination can result in a loss of particular value and valuable knowledge and skills. It contributes to increased turnover. There's high rates of turnover due to discrimination, which can be costly and disrupt overall workflow. There's examples of absenteeism. People who experience discrimination, they're going to be taking more sick days and or use other form of leave. There's reduced innovation, stifling creativity and problem solving, and biased decision making might even lead to poor choices and missed opportunities. So it has impacts on overall cost. Providing cultural competency and anti-discrimination training can oftentimes be costly. And when someone does leave, we're constantly recruiting and retraining, and so we're replacing these employees time over time, and it can be costly over time. And there are legal and regulatory compliance issues as well. discrimination lawsuits and settlements can in themselves be costly. And then adhering to anti-discrimination regulations and mandates, does require, once again, a lot of resources. When we don't comply, there might be audits and investigations, which can be time consuming, again, being expensive. And it's really important to recognize here that these costs can be indirect and often difficult to even quantify, but overall have an impact on financial health and sustainability of any institution. And a reputation impacts our community, our relationship with our community, damaging our reputation. How the community may not trust us in the services that we might provide. And then, of course, we could reduce our community partnerships, hindering those collaborations, once again, with community organizations and stakeholders. But ultimately, what happens on the inside is going to impact, how other systems that we work with as well. So ultimately might impact overall patient care when we don't address internal issues based on discrimination and other adverse, experiences. And so how do we address these particular issues? Again, they have to be, it's an ongoing process that requires a sustained commitment and effort from the individual level all the way to the systemic level. Our institutions, our organizations themselves have a role in making changes as well. So it's a multifaceted approach, has to target these different levels. And so at the personal level, highly continuously emphasize that we need to engage in critical self-examination to identify our own value systems and how that impacts, how we relate to each other, how we relate to our patients as well. So also identifying our personal biases, our implicit biases, our prejudices that we all do have, because they've been ingrained within our society and that we've been socialized into without much of our own awareness. But we really need to look at ourselves and our intersectional identities. Once again, I mentioned earlier that every identity that we have does come with certain advantages and disadvantages, and sometimes both. And so those are things that we really need to take a look at, and how we're impacted personally, and again, how that impacts others. In terms of education, we need to continuously seek out information and knowledge about different cultures, perspectives, and experiences. Very fortunate here in New Mexico to be a very diverse community in many ways. However, we can never be an expert in any one particular culture. I can't even say that I'm an expert within my own cultural background. It's always about continual learning, because even within research and intervention development, we still do not know about particular groups and how to address their particular issues. So we have to remain very culturally competent, and more so culturally humble, being okay with saying, I don't know, but finding those particular resources to fill the gaps that we don't have. Overall, so we can provide cultural safety and work towards health equity. And there's an unlearning process at this personal level as well. Again, like I said, we're all socialized, and we come with particular harmful stereotypes and overgeneralizations about particular groups. And so that takes a lot of time to unlearn. And if you are not part of a particular group, allyship is important. You might support a marginalized community or group and help advocate with them for their rights in general. And there's oftentimes training. Just recently, there was a bystander upstander training. Speaking up, this is a training that encourages us to speak up against injustices when we see them, how to be an upstander rather than just simply standing by and letting harassment or microaggressions or discrimination happen. And so look out for things like these type of trainings that we can in turn help others as they're dealing with this particular issues. When an individual is dealing, let's say, with a microaggression, it's often a shock and it's hard to respond, and we do need each other to address these particular issues in that moment. So this takes me to the interpersonal level. We have to take efforts to move beyond our habits of debate. Our society is very much a debate culture. And we have to move to ideas, or the idea of dialogue, which is an engagement in respectful and honest conversations about diversity, equity, and inclusion. And my hopes are to, at some point, develop some training on debate versus dialogue, so that we can continue to practice this and feel more comfortable about bringing these topics to the issue, to the table, should I say. And then active listening is more important when we're in dialogue. Listening to other stories doesn't mean that we have to accept a perspective. It's simply saying, okay, I can listen to you, but it doesn't mean that you have to take in exactly and agree with everything that that person says. Simply listening is enough. Of course, developing empathy and through perspective taking. And part of the reason why I wanted to bring in these 4 cases earlier is that we can really address that. So we can really start thinking about what perspectives can I take from listening to other people's experiences. Can I take a different perspective without judgment? And then trainings and conflict resolutions are often offered to address these interpersonal biases and discrimination situation. And so in terms of power sharing, this is another strategy that is, often people think that when one is giving away power, that it's completely being powerless. It's merely about sharing power. For example, it's about distributing decision-making authority in an equitable manner, so that everyone's voice is accounted for in any process. At the institutional level, much like we're doing here today, continual diversity and inclusion training. And sometimes some universities have mandatory trainings for all employees. Those are some things that we need to consider more and more. Think about mentorship programs. Are there particular mentorship programs that support marginalized learners, or support our communities of color who are beyond the trainee level and already out, faculty members, for example. We might even establish employee resources groups to foster a sense of belonging, which I'll talk a little bit more, that the School of Medicine has been developing over the last year or so. And then, of course, partnering with community organizations in whatever work that we do to help us address these systemic issues. And then finally, at the systemic level, and we have to continuously monitor, are we doing what we're saying that we're doing? So we need to identify what disparities exist within our own institution, what inequalities exist, et cetera, and how are we actually making change? So we need to continuously review our policies and procedures to ensure that we are addressing those particular issues that I mentioned earlier, whether it's about LGBTQ plus issues, gender issues, ableism, et cetera. And are we equitably addressing this within our policies? And of course, in terms of resources, can we distribute them fairly and equitably? And then overall, are we holding ourselves accountable? Do we have a system of accountability for addressing discrimination as a whole? So as I mentioned, the School of Medicine DEI office has been doing a lot of work. I have been part of a representative at these DEI meetings. And Dr. Fernander talks a lot about development of a beloved community, which is this intentional, proactive attention to the principles of being a Jedi, so belonging, advocacy, just valuing justice, equity, diversity, and inclusion. And so this is a continuously active practice to nurture this within our own academic medical community. And they provide different trainings. They've been, in fact, next week, here's a shout out to, or should I say, an invitation to an informal lunch. Anyone is welcome to attend this. So I just wanted to provide this. If you're interested in continuously working to improve DEI issues, this is one avenue. We're still in the process within our department of developing a full committee. And also our next steps are to also update our climate survey and look forward to that. But needless to say, if there are instances where you feel that you are mistreated in whatever manner, whether it's about discrimination or any adverse experience, of course, most people know about LEO, which is our Learning Environment Office, and this is primarily, it sounds like, for learner mistreatment. However, the Wayfinder is another resource on main campus that supports staff and faculty, and they provide support services and opportunities to learn more about other issues across the campus. So at this point, I do want to leave you with a couple of personal reflection. Like I said, it's really important that we continuously reflect on our own selves as a multicultural individual, a diverse individual with many identities. At some point, we are looked at as the different one, but also we also have our common ground similarities and experiences. But I encourage you to continue to reflect on, like, how can I, as a School of Medicine community member and a departmental member of Department of Psychiatry and Behavioral Sciences, contribute to the sense of a beloved community where we can respect those differences and honor our similarities. And really think about because we all have a role at every step and at that personal level, and how we might advocate at the institutional and systemic level. So what steps might you take to improve DEI on many levels? So this is not, this is a collective effort overall. So at this moment, I will leave any thoughts, comments, questions.
Thank you for your presentation, Dr. Chavez. And certainly, as a department, we are committed to continue to practice DEI to its fullest extent. So your contribution as the leader of DEI in our department is very much appreciated. And again, the department is in full support. And great presentation, very, very valuable cases you presented, Dr. Chavez. So we have 6 minutes left. There's time for discussion, questions. If you want to take off your slides, Dr. Chavez, so we can see the full audience and see who raises their hand physically or virtually. So folks, any comments or questions, just speak up. I think we have a chat question. People value your presentation, Dr. Chavez.
Thank you.
Folks, any comments, questions?
If there are any, I'm more than happy to take any. There's my contact information that you can easily email me, and more than happy to address any issues. Or if there are any particular trainings or presentations that you might like for your division, I'm more than happy to collaborate on any of that as well.
Well, thanks again, Dr. Chavez, for
Thank
your
you.
presentation and again for your efforts with DEI within the department. Thanks so much, Dr. Chavez.
Thank
Good
you.
to see